Yeah, okay. So good morning, good afternoon, good evening to everyone around the world, and welcome to the ACNS YNS webinars today. So we are so happy that we have two the chairman and also two speakers today, and also our discussion today, and also a very warm welcome to our colleagues in China, and also I would like to thank you, Professor Shiping, for broadcasting this in Richard channel. So today our chair is Professor Shingo Toyota, who is the director of the Department of Neurosurgery of Kansai Razzaque Hospital in Japan. We have two speakers today. Our first speaker is Dr. Xinghua Xu, who is a Deputy Chief Physician of the Department of Neurosurgery, the first medical center of Chinese PLA General Hospital in China. His topic today is minimally invasive surgeries for spontaneous hypertensive intracerebral hemorrhage, MISICH, a multicenter randomized controlled trial. Our second speaker is Dr. Syed Shahrear Razzaque, who is the Assistant Professor of Department of Neurosurgery of Suhawadi Medical College in Dhaka in Bangladesh. His topic is a minimally invasive, maximally effective microscopic supraorbital eyebrow approach for complex intracranial lesions. We have two discussions today. First discussing Professor Olisang, who is the Professor Chief of Neurosurgical Center, Clinical Hospital, Philadelphia, President of Ukrainian Association of Neurosurgeons, and Associate Professor of Department of Neurosurgery in Superior National Healthcare University. Our second discussion today is Professor Ahmed Farid, who is the Professor of Kabul University of Medical Sciences and the Chief of Neurosurgery Department of Aliabad University Hospital and the President of Afghanistan Neurosurgical Society. After that, we also have one learning point from our chair, Professor Shingo Toyota, who will talk about the role of keyhole keeping in the endovascular era. So to moderate the section with me, we have Aliaku and also Biswas, and also Joey Sam, and also Atik today, and also Hui Fam, who will join us later. So without further delay, shall I hand over the podium?
We have Prof. Kato here.
Professor Kato is here?
Yes, we can start with the remarks.
Yeah, just awesome.
Hello,
Professor
Hi, how are
Kato?
you? Sorry for the delay. Thank you for everybody.
You're just in time for the welcome remarks. Then we can
We're just welcome.
Yeah, thank you very much for everyone to join our YNS webinar. I think the program is very nice, so in fact, very much expecting two talks. Please go ahead.
Yes.
Polensky?
So
Wozniak?
shall I?
How are you?
Yes. Hello, Professor Kato.
How are you? How are you? Thank you very much.
Finally, good. Okay, thank you.
Okay, thanks.
So shall I hand over the platform to Professor Shingo to introduce the speakers and for the talks. Thank you.
Okay.
古田先生、ありがとうございます。
ありがとうございます。それでは先生、始めてよろしいんですかね。
もちろん、どうぞ。はい、お願いします。
I'm chairperson of this session. I'm Shingo Toyota from Kansai Razzaque Hospital. The first speaker is Dr. Xinghua Xu. Am I right?
Yes.
So please start your lecture, please.
Okay. Dear Professor Kato, Professor Shingo, and Professor Ben, thank you for giving me the opportunity to share our work on the topic for hypertensive intracerebral hemorrhage. This work was leading by Professor Chen, and this was a multicenter randomized controlled trial. And our study also has chosen as a plenary speaker, a plenary session speech on last year, the World Stroke Conference in Dubai in 2024. So the first was the background of this study. stroke is the leading cause of mortality and disability worldwide, according to the.
Sorry, I could not see your slide.
Okay, can
We
you
are
see
seeing
my
it. We are
PowerPoint?
seeing it, Prof. It's working well. We are all seeing it.
Okay.
Yes.
Okay.
So start.
So stroke is the leading cause of mortality and disability worldwide, according to the Global Burden of Disease Study. And the economic costs of treatment and post-stroke care are substantial. Although the prevalence of intracerebral hemorrhage is only approximately 1/4 that of ischemic stroke. However, the cause-specific deaths and years of life lost due to intracerebral hemorrhage exceed those of ischemic stroke. This was the global burden disease study in 2019. We can say stroke was a leading cause of death and disability. And in the past decades, China has been the country with the highest incidence rate of spontaneous intracerebral hemorrhage. We can say from 1990 to 2010, China is always the country with the highest incidence rate. Only 20% of intracerebral hemorrhage patients could live independently at 6 months after bleeding, which bring huge social and economic burden to the society and the government. Theoretically, surgery has the advantages of reducing hematoma volume and relieving perihematoma edema compared with conservative treatment. However, findings from randomized controlled trials have shown that for most patients with supratentorial intracerebral hemorrhage, the effectiveness of craniotomy for hemorrhage evacuation to improve functional outcome or mortality is uncertain, especially the stage 1 and stage 2 study. There are mainly 3 surgical methods for treating intracerebral hemorrhage. That is craniotomy, stereotactic aspiration, and endoscopic evacuation. Thus far, no specific surgical method has been proven to be the most effective. We carried out this study to investigate whether minimally invasive surgeries with endoscopic surgery or stereotactic aspiration that is done by the frameless navigated aspiration could improve functional outcomes in patients with supratentorial intracerebral hemorrhage compared with traditional small bone flap craniotomy. For endoscopic evacuation, this is a video of endoscopic evacuation of intracerebral hemorrhage. Minimal trauma and high hematoma clearance rate. We have reported this in the Journal of Neurosurgery in 2018. This surgical method can be assisted with neuronavigation, intraoperative ultrasound to accurately locate the hematoma and improve efficacy. So this is a video of the frameless navigated aspiration. This was with the electromagnetic navigation, which is a minimally trauma, and also we can this procedure can be performed bedside under local anesthesia, and however, it needs higher requirements for precise localization. So with this navigation system, we can place the catheter precisely and to improve the hematoma evacuation rate. So the second part is the method study design. This is a multicenter randomized controlled open label sequentially designed nonprofit study. It was registered in clinical trials. This was the registration ID. This study involved 16 neurosurgical centers across China. This is the hospital that take part in our study. So the participants, the inclusion criteria were supratentorial hypertensive intracerebral hemorrhage patients. The age was 18 to 80 years old, and the hematoma volume should be larger or equal to 25 milliliter. And the patient should be admitted to hospital within 24 hours after ACTUS, and the glaucoma scale score could be equal or larger than 5, and the pre-hemorrhage modified Rankin scale score should be 1 or 0. This was the exclusion criteria. The third is the randomization. Patients were randomly allocated to the endoscopy group, the aspiration group, or craniotomy group at a 1:1:1 ratio using a randomization system based on computer-generated number sequence. The procedure for the hematoma volume calculation. For the first time in a study, we use a free 3D slicer software to calculate the hematoma volume, because this method ensures that the error in hematoma volume calculation between different centers is minimal and the data are more comparable. Also, we have published a study to compare the TADA formula with software slicer. We published this work in journal Stroke in 2014. For hematoma positioning, we use a variety of methods to locate the hematoma. For example, we can locate the hematoma with a mobile phone application. This was a work published by our team to locate the hematoma with an Android mobile phone application, and this work was published to locate the hematoma with an iPhone application. This was published in Neurosurgery, and this was in the World Neurosurgery. Recently, we also use a mixed reality device, that is a HoloLens 2, to locate the hematoma, and this work has been published in journal Neurosurgical Focus. With this method, the hematoma position can be seen more easily, and we can locate the hematoma in 3-dimensional position. These were the procedures of 3 surgical methods for endoscopic surgery. We use this 3 approach to treat different hemorrhages, in different locations, in lobar location, in thalamatic location, and in the basal ganglia area. This was the procedure to do the endoscopic surgery with this the self-developed device, which has got the invention patent. First, we get into the hematoma, and then we do the hematoma evacuation under neuroendoscope supervision. This was the aspiration group. The target point was set near the posterior edge of the largest hematoma expansion on CT image. Available commercial frameless neuronavigation or free mobile device we have introduced, such as the Android application or the iPhone applications app to locate the hematoma. These were all used to improve the accuracy of catheter placement. This was a diaflow we do to do the bedside one-stop catheter placement of hematoma. First, patient underwent an bedside CT scan, and then we do the catheter placement under electromagnetic navigation. The procedure of catheter placement was done under the supervision of the navigation. For the small bone flap craniotomy group, a small bone flap to evacuate the hematoma as much as possible. Outcome, the primary outcome was the proportion of patients achieving a favorable outcome, which was defined as a modified Rankin scale of 0 to 2 at 6 months after hemorrhage. The secondary outcomes, including the quality of life measured with the Basel index, mortality rate at 1 month, days of NICU stay and hospitalization time and hospitalization expenses. For statistical analysis and quality control, 720 patients that was 240 patients in each group were needed to provide a 90 power and a 0.05 type 1 error probability to detect an effect size of 12%. The effect size was measured by our published work in Journal of Neurosurgery in 2018. The statistical analysis was performed on an intention to treat basis. That is, patients were included in the results statistical analysis based on the randomization result rather than which treatment the patient finally received. For the quality control work, the study protocol was published in Trials Journal in 2017. This was a study protocol published, and also all investigators have completed training and are proficient in performing all 3 surgical procedures. This was a meeting we held to train the participants or to train the investigators of this study. All 3 groups received the same continuous monitoring and pharmacological treatment according to the AHA guideline of intracerebral hemorrhage, and the surgery was performed within 6 to 48 hours after onset. The perioperative management was based on the 2015 AHA and ASA guidelines for the management of spontaneous intracerebral hemorrhage. Results: between July 1, 2016 and June 30, 2022, 1,226 patients were screened for eligibility, and finally 733 patients were randomly allocated. Finally, 721 patients received treatment and were included in the intention to treat analysis. This was the trial profile. Finally, we can see 20 lost to follow-up in endoscopy group and 26 in aspiration group, 24 in craniotomy group lost to follow-up. This was the baseline characteristics. We can say most patients were male, approximately 70%, and the mean age was about 56. The preoperative glaucoma scale was about 9, and the mean hematoma volume was about 50 milliliter. This was the baseline characteristics. We also record the hematoma location. This was the perioperative indicators, which include the operation time, intraoperative blood loss, hematoma clearance rate, stroke-related pneumonia, intracranial infection, hospitalization time, and hospitalization expenses. Let's introduce the items with statistical significance. We can see for operation time, endoscopy and aspiration were much shorter than craniotomy, and intraoperative blood loss was the same result. Another also very interesting result was the hospitalization expenses, which item seldomly reported in other studies. We can see in endoscopy group, approximately 92,000 yuan were cost for patients to receive endoscopic surgery. And for patients received aspiration surgery, the expenses were 77,000 yuan. And in craniotomy group, the expenses were 100,000 yuan. There was statistical significance. For the functional outcome, which was the primary outcome of our study, at 6 months, 70 patients lost to follow-up, and the loss to follow-up rate was 9.7, which was lower than our expected level, which was 10%. And 651 cases were followed up. We can see that in endoscopy group, 33.3% patient got a good outcome, and in aspiration group, 32.7 patients got a good outcome, and in craniotomy group, only 22.2% patients got a good outcome. The result has statistical significance, which means that patients underwent endoscopic surgery or aspiration and got a better outcome than patients underwent small bone flap craniotomy. For mortality rate and the quality of life measured by Basel index, there was no statistical significance. Also, this may be the reason may be that patients were limited, and after more patients recruited, maybe we can get a positive outcome, especially for the quality of life. This was the outcome of the functional outcome. We also do a subgroup analysis for deep hemorrhages, that is basal ganglia hemorrhage and thalamus hemorrhages. The probability of achieving a favorable outcome was 30.34% for endoscopic surgery, 28.4% for stereotactic aspiration, and only 40.8% for craniotomy. For patients with lobar hemorrhage, the probability of achieving a favorable outcome were nearly the same, with no statistical significance. The multivariate regression analysis showed that young age, better preoperative glaucoma scale score, small hematoma volume, and lobar hematoma location, endoscopic surgery or stereotactic aspiration surgery, and no intracranial infection were associated with a higher odds of favorable outcome. The last part discussion, we can say the AHA and the ASA guidelines from the 2015 version to the 2022 version. We can say that at first the recommendation was the effectiveness of minimally invasive clot evacuation with stereotactic or endoscopic aspiration with or without thrombolytic usage is uncertain. That's the 2015 version. In 2022 version, we can say that for patients with intracerebral hemorrhage of larger than 22 to 30 milliliters. Minimally invasive hematoma evacuation with endoscopy or stereotactic aspiration with or without thrombolytic use can be useful to reduce mortality compared with medical management alone. A variety of possible reasons have been proposed for why craniotomy fails to improve intracerebral hemorrhage outcomes, including operation beyond the optimal treatment time, insufficient sample size, and incomplete hematoma removal and relatively high growth rate. We can say that which was higher than 20% in stage 1 study. The stage study compared early surgery with the initial conservative treatment, and the results showed that early surgery had no superiority to initial conservative treatment. The stage 2 study demonstrated that early surgery might have a small but clinically relevant survival advantage to patients with superficial, that is, lobar intracranial hemorrhage. The MISICH 3 study found that for moderate to large intracerebral hemorrhage, minimally invasive catheter evacuation followed by thrombolysis did not improve the proportion of patients who achieved a good response 1 year after intracranial hemorrhage compared with standard medical treatment. More recent study, the SWITCH study published in Lancet 2024, showed that decompressive craniectomy plus best medical treatment might be superior to best medical treatment alone in people with severe deep intracerebral hemorrhage. 44% participants in decompressive craniectomy plus best medical treatment and 58% in best medical treatment alone had a modified ranking scale of 5 to 6 at 6 months follow-up. This was the result, which show that decompressive craniectomy plus best medical treatment may be better in patients with severe deep intracerebral hemorrhage. And the INRICH study published in the New England Journal of Medicine in 2024 demonstrated that early minimally invasive hematoma evacuation significantly improved functional outcome at 6 months, especially for the lobar intracerebral hemorrhage, and reduced short-term mortality and hospital utilization. This was a study published in New England Journal of Medicine. Our study was the first to large-scale comparison of effects of minimally invasive surgery and craniotomy in the treatment of hypertensive intracerebral hemorrhage. It reveals that the economic cost difference of different surgical methods and provides data support for the allocation of medical resources. Minimally invasive surgery reduces medical costs while improving treatment effects, which is of great significance for improving patients' quality of life and reducing medical burdens. Limitations. Our study has limitations that lack of control group for medical treatment, which may be of more significant importance. There is room for further improvement in the reliability of the research results, and different surgical experience and surgical method preference of researchers in different centers may influence the results. To conclude, compared with small bone flap craniotomy, endoscopic surgery and frameless navigated aspiration significantly improved the functional outcome and quality of life in patients with moderate to large supratentorial hypertensive intracerebral hemorrhage, especially for patients with deep hemorrhages. Frameless navigated aspiration and endoscopy surgery were also more cost-effective compared with small bone flap craniotomy, and more powered clinical data are warranted to compare endoscopic surgery with stereotactic aspiration or even with conservative treatment. Thank you. That's all.
Thank you so much. So any comment from the chair and also Professor Shingo can also invite our discussion to comment on the presentation.
Hi, thank you very much. This is very
That is because you have signed
presentation,
into
I think.
2 different devices.
My question is, what is the main merit of the good prognosis of the endoscope?
We defined the good prognosis as the prognosis measured by the modified ranking scale that was 0, 1, or 2 points at 6 months follow-up.
Mm-hmm. And how about the hemostasis of the setup? What is your how about your setup of the endoscope for hemostasis?
Okay, for most cases, no special hemostasis procedures are needed to coagulate such as the vessels, because for hypertensive intracerebral hemorrhage, when the patient underwent the surgery, usually the bleeding has stopped. And for patients with obvious bleeding, such as a small vessel, we can use coagulation for the suction and to do the with bipolar coagulation.
Mm-hmm. I see. And any question?
Any comments from Razzaque?
Hello. Yeah. Good evening, everyone. I'm Dr. Rajkumar. I'm currently a fellow at Bantane Hospital under Professor Yoko Kato. First, I would like to congratulate that it's a very good study that can guide towards what the decision is. But I would like to ask whether the speaker would like to use endoscopic evacuation or aspiration in his daily practice. What does he prefer?
Okay, thank you for your appreciation and thank you for your question. In more previous years, such as the year we published the work in Journal of Neurosurgery, we prefer to do the endoscopic surgery because for this surgery, most of the hematoma can be evacuated and the hematoma clearance rate can be up to maybe 90% at 24 hours follow-up CT scan. However, recently, more and more patients were even older, and many patients had taken the anticoagulant drugs. For this patient, maybe to do the catheter placement with electromagnetic navigation were preferred in our center, because with this procedure, the patients need not to go into the operation room. We can do this procedure bedside, and with this procedure, we can say that we can also get a very good outcome compared with traditional small bone flap craniotomy. That's my answer. Thank you.
Thank you so much for your kind response. Thank you.
And any question?
Any comments from Professor Razzaque?
Yeah, okay. Thank you very much. Thank you for excellent presentations. Really, Professor Xu, it's really good job. As we can see, from study to study, the results of minimally invasive methods gets more and more effective. And finally, I expect that we will obtain the result where we will be able to recommend these methods for routine use in patients with acute stroke. The reason, of course, is in, first of all, the patient selection, in improving patient selection, and second, in the improvement of methodology of performing these procedures. Concerning this work, I have some question to Dr. Xu. First of all, did you perform local thrombolysis in patient in the aspiration group or not? Because there is another option for minimally invasive local thrombolysis. Did you perform it in group of aspiration?
Yes, we inject urokinase because this drug is very cheap and the RTPA was relatively very expensive.
Okay, I see. Yes, okay. So you didn't separate the group of local thrombolysis from group of aspiration. It's like it was in this group. And another question about the craniotomy group. Did you have cases where craniectomy was performed in this group or not? Did they sometimes require the craniectomy? Or no, only regular craniotomy for evacuation of the hematoma?
Yes, but in this group, I remember that only 2 or 3 patients received the craniectomy procedure because only when after the hematoma was evacuated, we can say the brain tissue was swelling out the bone flap. We do the craniectomy. And in this study, we also recorded the number of cases which underwent, for example, the rebleeding. And generally, the rebleeding rate of patients who underwent a second surgery was relatively low. And maybe because the number of patients underwent a second surgery was very limited, so it's a bit difficult to do more discussion or analysis, and we have reported the number in our study, and the work was published last year in journal BMC Medicine. Thank you.
Yeah. Thank you. So thank you, and my congratulations. It's really one more step forward in management of acute hemorrhagic stroke. Thank you.
Yes, thank you.
Any question? My question, is the endoscope setup is all similar in all the institute or hospital? Is the setup similar?
Yes, the procedure is similar in all institutes take part in this study because all the investigators has underwent a course, which we do the course, provided the course to teach every investigator to master the procedure of endoscopic surgery to do the surgery. And only after they take part in our course and master the all these 3 surgical methods, they can take part in our study. Thank you.
Okay.
Yes.
Any question?
Yeah, can I ask a question? Thank you, Professor Xu, for your really good study. I've also started doing the MISICH using the endoscope. So we have a few cases and want to ask about your opinion. So In your cases, do you use the endoscopic holder? That's the first question. And my second question is for the tunnel or shift that you use. Is it the balloon guided shift in China, or you use a homemade shift for your center, or all the centers in the study use the same type of the tunnel or shift in the surgery?
Okay, thank you, Professor Ben. For the first question, we do not use an endoscopic holder, especially in this study. For two reasons. First, the endoscopic holder was relatively expensive. And the second reason, most endoscopic holder up to now were not very easy to use. Especially we need to change the angle or the position of the endoscope very frequently. For the second question, the tunnel which provided the path for the endoscope, it was a self-made, it was a new invent by Professor Chen. Professor Chen invented this path, and we provide this product to all the centers in our study. So we use the same endoscopic tunnel. Thank you.
I see. Thank you. Thank you so much. Congratulations.
Okay.
Raja?
If I may ask one question, rather comment rather than question, because you have showed the comparison between MIS craniotomy and endoscopy, and the inclusion criteria were very much similar to the ENRICH study that was published. So these patients that actually have in a real practice, you may not get like that in your trial. In ENRICH study, around 11,000 patients were screened to get this 300 patients. That is only 3.2% were actually eligible for the trial. And all the patients like yours had also premorbid MRS of 0 and 1. So these patients were obviously supposed to have a good outcome after surgery. So this trial may not reflect the normal patients that we get in our clinical practice, which is not less than 24 hours. We always get patients after 2 or 3 days in a tertiary center, and also they all have a premorbid MRS higher than 0 and 1. So what is the number of patients you actually screened to get your standard population in this trial?
1,226. We screened to get our 721 patients. Because in China, for most patients with intracerebral hemorrhage, the hematoma volume was relatively large, especially in the department of neurosurgery. For patients with very less hemorrhage, maybe they are presented with not very severe symptoms, and they usually go to the department of neurology. In department of neurosurgery, patients usually have a larger hematoma volume with more severe presentations. Thank you.
Thank you. Thank you very much.
Okay. Any question? I'm sorry, time is limited, and this is very valuable presentation, I think. Thank you very much for Xinghua Xu, Dr. Xinghua Xu. Thank you very much. And the second speaker, Dr. Syed Shahrear Razzaque. Please start your lecture, please.
Yes, thank you, Professor. A very good afternoon to patrons and my dear colleagues. Today I am going to present. At first, I would like to share my screen. Can you see?
Yes.
Yes.
Okay. I am going to present our institution's case on microscopic supraorbital eyebrow approach for some complex intracranial lesion. We all are young neurosurgeons here. We are giving description in the perspective of our young neurosurgeon group. This is my center. In the left, this is the Syed Medical College where I work, and the second on the right side is the Dr. Shiazul Islam Medical College Hospital, where we work in private setup. Now, why keyhole? Nowadays, keyhole is a very important topic in neurosurgery, not only neurosurgery, but the all the branches of surgery. Keyhole is not about just size, it's a philosophy. The aim of the keyhole surgery is not only cosmetic, but it also has some ethical value. If surgery required, then how to minimize the damage to the normal structure? And to answer this question, here comes the keyhole technique. Very long concept, traditional funnel-shaped surgery. There is contemporary reverse funnel microsurgery in keyhole corridor, where there is a wider operative field rather than narrow corridor. Barely able to see the scar mark. Here we can see the supraorbital eyebrow incision is very minimally visible in the left side. In the right side, the patient underwent for frontal glioma, and in the left side, the patient went for an aneurysm of the brain. This presentation discusses our institution's experience with minimal invasive supraorbital eyebrow craniotomy for managing some complex intracranial pathologies. Am I audible?
Yeah, you're audible. Please continue.
Here, our study method, it was a prospective type of analysis conducted in the two medical college hospital. During the last 3 years, total 32 patients were enrolled, and all patient characteristics, lesion types, hospital stay, 30-day complication rates, and cosmetic results in accordance with patient satisfaction were analyzed. First, in the tumor group, we did tuberculum cella meningioma, mostly 4 patients, followed by clinoidal meningioma, pituitary macroadenoma, craniopharyngioma, olfactory group meningioma, frontal glioma, frontal metastasis, and 1 orbital tumor. And in vascular lesions, mostly aneurysms, the ACOM was the highest, 5 patients, and followed by basilar top 3 patients, PCOM 2 patients, and ICA bifurcation aneurysm 2 patients, and ICA ophthalmic artery aneurysm 1 patient. Then how we did it? At first, we placed the patient in Mayfield head holder. Head is positioned in extension and rotation is fixed according to the location of the lesion. We give this incision inside the eyebrow for better cosmetic result. In our early cases, we used to give it above the eyebrow, but after giving through the eyebrow, we got better outcome. And after the dissection, we never use bipolar on incision edges and protect it from the thermal heat generated from drill to protect the hair follicle and skin on the margin. Then we shape the muscle and gallial flap as one, so it helps to reconstruct the layers at the end of the surgery. And we dissect usually medially up to the supraorbital neurovascular bundle and laterally up to the keyhole. This is after the dissection, and after dissection, we expose the keyhole, and the lateral extension of the bony exposure is for keyhole and medially up to the supraorbital nerve. And then using a perforator or sometimes a cutting bar, we use a small bar and connect the bar and do a craniotomy of about 3 into 3 centimeter. And in the most of the cases, we usually remove the supraorbital ridge. In some very few cases, we didn't remove the supraorbital ridge, like some frontal glioma or frontal metastasis. But on usually other skull-based tumor cases and aneurysm cases, we remove the supraorbital ridge using a bone chisel. Then dura is cut in curvilinear fashion and reflected, keeping the base towards the orbit, and take-up sutures was taken. Here we can show some representative cases, like this is a basilar top aneurysm, and this is the after surgery, and this is the patient. We can see the incision was given through right eyebrow. Patient is neurologically intact. And here we can see a video. Yes, this video showing the operative procedure for a basilar top aneurysm. First, after exposure, we did the Sylvian Fisher dissection, started from the proximal portion to distal, and through using a sharp 1 millimeter syringe, we did the dissection. Then the ICA was exposed, and it was keep going distally. Then the ICA bifurcation was exposed, and then the dissection continued, and posterior clinoid process was exposed, and then the drilling of the PCP was done, and then the aneurysm, basilar top aneurysm, came in view. Then it was dissected for taking primary control. We just exposed the area, but we didn't take the primary control. It was not needed. At first, a straight clip was applied, and when a residual portion was seen, then another mini clip was applied for the residual portion. And we already showed the complete obliteration of the basilar tip aneurysm. Then another case, another basilar top aneurysm. This is the postoperative outcome, complete obliteration of the aneurysm. And this is the patient. We can see through the right eyebrow incision, and patient is neurologically completely intact. Here a video. The quality is poor. I am sorry for that. We gave the incision through the eyebrow. Then monopolar cautery was only used on the fascia. Then a bar was made, and then craniotomy done, dural incision, and then again Sylvian Fisher dissection using sharp instruments. Optic nerve and ICA was exposed, and then the basilar top, including 2 PCA, was exposed. Preparation was taken for proximal control, but also in this case, we didn't need any temporary clip application. We did clip just one straight clip, and it completely obliterated. Then another case, this is a very large ruptured ACOM aneurysm. Here we can see bleed in the cistern and in the third ventricle. And this is the postoperative image. We can show the complete obliteration of the aneurysm, and clip is visible. And this is the patient. She was neurologically completely intact. We entered through the left eyebrow incision, and this is the video after exposure and after Sylvian Fisher dissection. The optic nerve and ICA was exposed, and then the branch of ICA was exposed, and we exposed the ipsilateral A1, and then contralateral A1, and then at first we take temporary control of ipsilateral A1, and then we took control of contralateral A1, and then the aneurysm neck dissection started. Here we can see the aneurysm neck. It was separated from surrounding vessels. Place was made for the clip insertion, and then one straight clip was applied in the neck, and then the temporary clip was removed, and hemostasis was achieved using Surgical. Then another case, we can show some tumor cases, like this is a 3 by 3 centimeter size left clinoidal meningioma, and this is the post-op picture showing complete removal of the tumor, and this is the patient. We can show the incision through the left eyebrow. It is just 1 month follow-up picture. And here a short video. The patient was positioned in Mayfield head holder with slight rotation towards the opposite side. Incision was given through the eyebrow. A small bone flap was removed, and then at first tumor was identified and separated from the its base by bipolar cautery, and through the bipolar cautery, at first we identified the opposite side contralateral optic nerve, which was not involved. We protected it, and then medial to lateral burning of the base of the tumor was made, and through this coagulation we identified the ipsilateral optic nerve. It was separated from the tumor, and very carefully we exposed the ipsilateral ICA, which was attached with the tumor, which was sharply dissected, carefully dissected, and then the completely the base was separated from the tumor. Then the parenchymal surface was burned and shrinked. The tumor was large enough we could take it in one piece, so then we started taking it in piecemeal fashion, and after taking 4 to 5 large pieces, the last piece we took and complete removal of the tumor with the coagulation of the base. The dura was closed in watertight fashion, and this is the skin closure. Then it is a tuberculum sella meningioma. The post-op picture showing the complete removal of the tumor, and this is the patient. Very minimum scar we opened through the right eyebrow. Then another case, this is a grade 2 diffuse fibrillary astrocytoma, and this is the post-op picture, complete removal of the tumor, and this is the patient. We already showed this patient. He is very happy with his scar mark, and this is a very large pituitary macroadenoma with suprasellar extension and extension into the lateral ventricle. In this patient, we approached through supraorbital keyhole route, successfully removed the total tumor, and we mobilized the olfactory nerve and did the frontal orbital corticotomy to reach the ventricular part. But unfortunately, the post-op CT showed tumor bed hematoma, the only one tumor bed hematoma in our series. But luckily, the patient was stable and no further intervention was needed. This is the patient. He is clinically completely okay. This picture was taken on 14th POD. The incision mark is very barely visible. And our last case, this is a bony orbital tumor originated from orbital roof. A 9-year young lady. The Post-operative picture showing the removal of tumor and reconstruction of the orbital roof by titanium mesh. And this is the girl. She is happy with her scar mark. And no surgeon is without complications. We also had some complications. In our 30-day complications series, the most patient we found with periorbital edema, followed by numbness in the periorbital area and inability to raise the eyebrow. But all these three were temporary and removed in all patients after 1 month. Only 3 patients in our series among the 32 patients, they were not personally happy with the unacceptable scar. 3 patients showed CSF leak. Only 1 patient needed re-exploration and leakage identification and closure. And 1 patient I already have showed tumor bed hematoma, but no intervention was needed. And our mortality rate was 0. And 1 patient in 1 pituitary adenoma, mostly a acromegally patient, we needed revision of the surgery through the pterional approach in the second setting. Because of huge brain swelling, we could not approach through the eyebrow approach. Here are some examples of ugly scar. 2 of patients, they were not satisfied. They were within our earlier series. They had supra eyebrow incision, which actually we changed in our later patients. This is periorbital edema on the first POD, but in the 1 month follow-up, the incision is barely visible. This is a subgaleal CSF collection on the second POD, but on 3 months follow-up, it is very much acceptable scar. And this is a first POD patient, a aneurysm patient, and this is the 7th POD. The periorbital edema mostly subsided, and in 3 months follow-up, it is very hard to say where the incision mark is. So in our study of 32 cases, there was very shorter hospital stay. Our mean was 3.2 plus minus 0.4 days, which was very low in our previous, comparing our previous cases where we used the pterional approaches, and few complications, mostly are temporary. Patient reported good cosmetic results and high satisfaction. Long-term follow-up showed stable or improved neurological function in most of the cases. But we have to remember all cases are not suitable for keyhole surgery, especially very large extensive skull-base lesions and hugely swollen brain due to acute diffuse subarachnoid hemorrhage are not amenable to keyhole approach. And of course, it has a long learning curve. Careful selection of patient and skill is the key to success in case of keyhole surgery. This is our setup. In previously, we used the Hag-Street Muller microscope, and for last 6 months, we are using Sanma Yoko exoscope imported from India. And this is our present setup. We use exoscope in most of the cases. And this is my mentor. He is an assistant professor from Dhaka Medical College Hospital, Dhaka, Bangladesh. And last but not the least, I would like to thank Professor Yoko Kato Sensei for giving me the opportunity to present in this esteemed forum. Thank you for your patient hearing.
Thank you very much for your very excellent surgery. And one question from Q&A from Dr. Rashid Bareks. If aneurysm ruptured, how you manage, how you decide to use left or right side for aneurysm? That is question.
sorry, yeah, I couldn't hear. Can you repeat it, please, Professor?
Okay. If a aneurysm ruptured, how will you manage? And how you decide to use left or
In
right
our
side for aneurysm?
mostly which are the midline aneurysms, we use right-sided approach because dominant hemisphere is left side, and if acom aneurysm, then we usually avoid the hypoplastic segment. If the both segment is similar, then we usually choose the right-sided approach. And in all our aneurysm cases, no aneurysm actually ruptured perioperatively, but previously in terional approaches and some other cases, we found some ruptured cases, perioperative rupture. Actually, we use two sucker, a very rapid sucking and cotton compression, and then if the already temporary placement place was exposed, then we use the temporary clip, and if it is not exposed, then usually we use permanent clip according to the neck location temporarily, and then the closing of the bleeding, we actually replace the permanent clip again.
Okay. Can I ask you a question?
Yes, yes.
What is the anatomical indications for vaginal top aneurysm? I want to ask you.
Through eyebrow approach, you are asking for?
Yes.
Yeah, for through eyebrow approach, actually, it need to be high up the neck. The sagittal view, if in the sagittal view, sagittal city, the neck is above or at the level of the dorsum sella, then we can approach through keyhole approach. Actually, low-lying neck cannot be approached through this approach.
Thank you. Any question?
Any comments from Razzaque?
Sorry. Thank you. Thank you, Dr. Syed. Thank you very much. Excellent presentation. Great cases. Good, very good surgery. Of course, now this minimally invasive approach is in big trend. It's like a fashion. But as a person who started to do this approaches 25 years ago, I must say that they have some disadvantages, of course, these approaches. First of all, the cosmetic results is not so as good as you can meet in the literature. In 3, 5, 6 years, there is a cosmetic defect because this small flap resorbs and depresses, and especially skinny patients have really cosmetic defect, and I sometimes must send them to cosmetologists to put some kind of silicone and so on, so on, so on, so on. The first, another problem is the sensitivity and eyebrow movement. As you shown, up to 10% has a problem, and that's true, and even more patient. And only cosmetic effect of the scar after the surgery sometimes is very visible and very noticeable. So that is why I always discuss with the patient the sense of this minimally invasive approach, and I explain. And very often patients choose the regular supraorbital craniotomy. Sometimes we modify the incision on this kind of wrinkle above the brow in patients with the visible wrinkle. It's also possible. What I wanted to warn you not to use only this approach, but to separate the patient for this kind of surgery, and also to have in your armamentarium, to have the regular approaches like a frontolateral, like a regular supraorbital approach. Sometimes I think they could be more reasonable for the huge tumors, for the extradural procedures, for extensive bone drilling during surgery. This is my option. So, and now we are surviving the a fashion of mini-invasive surgery, and in a couple of years, I think all the approaches will take their real place in our practice. In general, thank you very much. Really good surgery. Thank you.
And many questions. And okay, please start the question.
And with Roger, you want to say something?
Okay.
Yes, I would like to say one thing, that in generally when we talk about keyhole approaches, we usually spare the supraorbital nerves.
Raja, we cannot hear your voice.
Can you hear me now? Can you hear me now?
Yeah.
So I was talking whenever we do a keyhole approach supraorbital, we generally preserve the supraorbital nerves and vessels. But in your case, I saw the incisions extending far medial. So did you really intend to preserve the supraorbital vessels and nerves? Because generally if we do that, the incision should not cross the mid-pupillary line. That is what the standard teaching is. But I saw it very different in your videos.
Actually, our skin incision is up to the medial portion of the eyebrow, within the eyebrow. But during excising the fascia, we cut the fascia, keeping the neurovascular bundle medially. We didn't cut the neurovascular bundle. Just only the skin incision was given up to the medial margin of the eyebrow.
Okay, but the vessels supply the scalp. So when you cut the skin till the gallia, the vessels are gone already. So did you have patients post-operative numbness over the forehead scalp?
Yeah, we showed already about 4 to 5 patients have post-operative numbness, but actually we didn't cut in single layer. After skin, the gallia is cut in another layer. Gallia is not cut in the neurovascular bundle. Gallia is cut medial to the neurovascular bundle.
Okay, but the nerves and vessels are located in the second layer of the scalps. So it cuts with the skin and connective tissue.
In all cases, we see the nerve. Neurovascular bundle is usually in our front, and we keep it medial to our incision.
Okay.
Next question.
Yeah, cool, maybe. Oh, Dishot, you want to make comment?
Yeah. Thank you, Dr. Shahrear. This wonderful presentation and interesting cases with excellent results. Just wanted to ask, what do you do in case of, how do you deal with the frontal sinus after the resection of the tumor? And do you place fat into the sinus, or any other techniques you prefer to use?
Usually, before giving incision, we study the CT scan films, the extension of the frontal sinus, and in most of the cases, about 30 cases in our series, we didn't expose the frontal sinus at all, because the bony work was laterally. Frontal sinus was in the medial portion. In 2 cases, the frontal sinus was exposed, and we covered it with gel foam and blocked it with bone wax.
Okay. Any question?
Yeah, Aniaku, you have a question? Or No, I want to ask the questions for your cases, and really congratulations on your results. But I would like to first make some comments for the scars. So so essentially, I think you can discuss with oculoplastic surgeons in your cases in case you want to have a better outcome of your scars. If you want to use, there are some types of the incision, like you can have the supraorbital transciliary on the subbrow or the lid crease incision. So personally, I think the lid crease incision has the best the cosmetic outcome. But usually you come with the cosmetic need to have. It's better to have an oculoplastic surgeon to help you with that case. And another case is, of course, it's about the different type of people. Some races are more, it's more easy to form scars. So we need to also take care of that. So, and also the only only comment for you is the basilar aneurysm. So I think like the principle of the aneurysm surgery is to apply is to have, at least you need to have the proximal control. So in the case that you have the basilar aneurysms, do you think you can give the proximal control in the basilar trunk in your views?
Yeah, in my video, I already showed we expose the area for the proximal control. In both cases, we didn't take the proximal control, but before dissecting the neck, we expose the area below for taking the temporary control. But as it was not ruptured, so it was not needed. But we always expose the area for temporary control.
I see. Have you tried using the endoscope as well in your case?
Yeah, we have endoscope for last 4 to 5 cases. We are started using it actually at the last stage of the surgery after clipping to see any residual portion or any inadvertent vessel was cast within the clip. To exclude this, we used endoscope. Actually, we don't have very good quality endoscope in our setting, and endoscope has different learning curve. Actually, we started using it, but I think we need more time to go complete endoscopic keyhole approach.
I see. So another sub question is what type of the aneurysm clip applicators you use? Because from here, the suborbital to the basilar, I think you need a long applicators, especially a single strap aneurysm.
This is the funny part. We actually have no special setup. Just the same setup we used in terminal cases, transcavernous cases, the same setup and same clip applicator. We reached that distance.
I see. Thank you so much. Oh, and there is only a short question in the chat box. So if there is large frontal sinus, so would you use this approach? This is from the chat box. Frontal sinus. Would you use this if there is a large frontal sinus?
Oh, I already have answered. If frontal sinus is inadvertently exposed, then we usually pack it with gel foam and then close it using bone wax.
I see. Thank you so much.
Any question?
I think we can proceed to your learning point, Professor. Yes. And Professor Shingo, maybe you can talk about the learning point of today. I think we have done for the second.
Okay. So, and is the session is finished, or am I start and do I start the lecture here?
Yeah, you can start.
Okay. Okay, so now let's start. Thank you for Chairman. And now I present exoscopic keyhole clipping for unruptured aneurysm. Next, please. Next slide.
Okay.
Just a moment. Okay. Even in the endovascular era, microsurgical clipping can achieve excellent clinical outcomes, especially in MC aneurysm. Several effective keyhole approaches have been previously reported. Next. The OBI has recently been introduced for neurosurgery. Now we present our experience with the use of OBI during keyhole clipping of unruptured MC aneurysms. We performed terminal keyhole clipping of unruptured MC aneurysm using OBI in 31 patients. Next, we present exoscopic terminal keyhole approach. This is our setting of exoscope. Main monitor was placed facing the surgeon at the end of the imaginary line extend through the cerebral fissure. Two movable sub-monitors were placed at 55-degree angle to the left and right. Next, please. We use 3 sets of 4K 3D monitors. Main monitor was placed facing the surgeon at the end of imaginary line extended through the cerebral fissure. Next. Next slide. Next slide. And this is the right exoscopic terminal keyhole approach. 15mm skin incision was made. After subfascial dissection, the temporal muscle was split in the direction of the muscle fibers. 30mm keyhole craniotomy was created posterior to the McCarthy keyhole, such that the lateral edge of the spinal ridge was the center of the craniotomy. Next slide. I present unruptured right MC aneurysm. Next slide. Using OBI, cerebral fissure was dissected with standard microsurgical technique with standard micro instrument. And this is the by standard 2. M1 was secured for temporary clipping. It is under the OBI and the exoscope. The aneurysm was identified and carefully dissected. At first, I tried to dissect a vein from the aneurysmal dome and the M1 temporal occlusion. But I found that it was not so easy. Then I decided to clip without dissection of the vein. And the neck was clipped using 2 clips. This is the first clip. So I think the operative field is not so narrow. The second clip. The neck was clipped using 2 clips and preserving the vein, adhering the aneurysmal dome. ICG video angiography showed complete neck occlusion. Next slide. 3D CT angle after surgical clipping showed the craniotomy diameter almost 28 mm. The aneurysm was completely clipped using 2 clips, no complications. Next, please. All the procedures were successfully accomplished using OBI alone. Mortality and morbidity rate was 0%. Next, please. Comparison was made between the exoscope group and the microscope group. This is a historical control study. Mean aneurysm diameter, craniotomy size, duration of the intradural procedure, blood loss volume, and similar between the groups. The mean ICG dose was significantly lower in the exoscope group. Next, please. Several approaches, terminal keyhole approaches, have been previously reported. Professor Mori has reported very sophisticated keyhole approaches. Next, please. Next, please. Our approach is sphenoid-rich keyhole approach. This is a subtype of the terminal keyhole approaches. Next. In the sphenoid-rich keyhole approach, keyhole craniotomy was created posterior to the McCarthy keyhole, such that the lateral edge of the sphenoid ridge was the center of the craniotomy. With this craniotomy, the Sylvian fissure also emerges in the center of the craniotomy. Next, please. Question: what is the significance of exoscope in terminal keyhole approach? We think that it is flexible angle of the operative visual axis. Next. We have already reported 10 reports on exoscopic surgery, and flexible angle of the operative visual axis is the maximum merit of the exoscope. Next, please. The significance of exoscope in terminal keyhole approach is flexible angle of the operative visual axis. For example, microsurgery under the eaves. Next, please. And microsurgery looking down at belly. Next, please. Via keyhole approach, to fully dissect Sylvian fissure and the structures around the aneurysm was widely as possible. The surgical visual axis needs to be tilted fully in all directions. When the keyhole approach is used, the craniotomy is smaller and the visual axis is steeper than with the conventional craniotomy. Use of the exoscope allows the surgeon to perform surgery in a comfortable position, even when the scope is tilted fully. This makes it possible to perform precise microsurgical maneuvers. Next. Next, please. Conclusion. Exoscopic terminal keyhole approach, clipping for unruptured aneurysm was safe and efficient and not inferior to using surgical microscope. Next. Thank you very much for attention. Some question?
Thank you so much. Any comments? Professor Oliseng, any comments from you?
Professor Toyota, thank you very much for your really like highlight of keyhole surgery with exoscope. I've just started my practice with exoscope for about 1 year only, and I have my own impression. I like it very much. First of all, because it provides better visualization than micro. I have a Pentero 900, but exo, especially when I work in the internal acoustic canal and I have to separate the nerves, exo much better for visualization. What I noticed that my assistants do not like exoscope because it's not convenient for assistant. They better for them to have a binocular vision in micro together with me than to stand aside with another angle of view, and they must how to say to work with the inconvenient field and so on and so on. What I noticed, we have a think about it. Maybe when we work face to face, it's easy because you can just turn over the picture to the another screen and that's all. But when we stand side to side, it's quite not convenient for. And another disadvantage, sometimes we have some blicks on the screen. We can provide the absolutely dark wall behind our back. If we have some additional light, you will see it on the screen. And for me, I know it disturbs. I don't like, so that is why I always try to put the screen in a position far from some additional sources of light behind me. So, but in general, I agree with you. It's really excellent tool, and it has real place for in the OR, and its combination with microendo, and it's a very wise solution for many pathologies. So thank you very much.
I think that on the program of the assistant and is somehow important, I think. And in microscope, the angle of the from between the surgeon and the assistant is almost 90 degree, I think. But and in X-scope, it should be 45 degree, I think.
At least.
That is, it's okay. And if you keep the 45 degree, I think it's not so problematic.
Okay, thank you. I will try. Thank you.
Next question.
Any comments from Professor Priest?
Hello. Assalamualaikum. Thank you very much, Christopher. Nice presentation and achievement for you, Professor and Dr. Syed Shahrear. Congratulations. Thanks very much. It was very useful and good achievement. Thank you very much.
Thank you. Let's see.
And also congratulations for Ben for your publication.
Oh, okay. Thank you so much. So, any comments from the floor? Yes.
Sam,
So,
you have some question?
Sam,
Hi, Kato Sensei. Yeah, thank you.
Hi, konbanwa. Hi, how are you?
Oh, come on. Hi, Ben. Thank you, Professor Toyota.
Thanks.
That was a very nice presentation. I had doubts previously about, clipping of aneurysms using the exoscope, but like you have demonstrated that MCA aneurysms can be clipped quite well. And I think the portion where you said that where you can adjust the scope and look compared to a microscope where you can go underneath, I think that's a very good point compared to the microscope. I'm just wondering, out of all the aneurysms that we have experienced, which do you think is good to start off with if we were to use the exoscope to clip? Is there any easier aneurysm in terms of learning curve and from your experience? Thanks.
Thank you very much. I think I want to maybe the resident should be start with microscope, I think. And after that, and they can use the exoscope. It's my opinion.
Okay, so it's after the microscope, it's another.
Yeah, I think so.
Yeah, compared to okay, right. Thanks.
Maybe Sam, you can join the Toyota Sensei at the August Congress, I think.
Okay.
In Osaka.
Yeah. Thank
Please.
you.
To see is very important.
Yes.
Okay. Yes. Thanks.
Just can I just a short question very fast? I want to ask for deep-seated aneurysms like the ACOM or even posterior circulation aneurysms. So sometimes the viewing angle is it might be the endoscope if the aneurysm is deep. So do you do both, or do you combine it, or do you use only exoscope alone as well? Another thing is there any ICG overlaid on the field? Yes.
Thank you. In echomanerism, I only use exoscope, not use the endoscope. I think it's enough for me.
I see. Thank you. Thank you so much. So are there any comments from the floor? So if not, I think we can conclude the session today. And first of all, I really thank you, Professor Professor Shingo Toyota, for your great presentation. And please share with us your August event, if possible. Any final remarks from Professor Kato?
Yes, I think minimally invasive is it's a trend now. I think the good for the patient and also the good for the surgeon, both sides, I think. But the indication is very important. So, such as a supraorbital hemorrhage case is not a good indication for eyebrow approach, I think. So sometimes the huge edema or sometimes premature rupture has sometimes occurred during surgery. And also the instrument is another important issue, I think. So I think someone who wants to do such kind of a keyhole approach needs some more practice, I think. Otherwise, it's sometimes contraindication, I think, for younger generation. So that is my today's comment. And maybe I think in the future, even bypass surgery is getting number is smaller because of the intracranial vessel disease, such as stenosis or occlusion. It may be treated by medicine. So even the bypass surgery is getting the number is smaller, I think. So I think it's a good time to do if you want to do the bypass surgery now. So thank you very much, Toyota Sensei.
Thank you.
It's a wonderful talk. Thanks so much.
Thanks.
Thank you.
Toyota
So,
Sensei is
thank
very reliable doctor.
Yes.
Young doctor. Yeah.
Thank
Young
you so much.
doctor.
Thank you so
Yes,
much.
thank you very much.
Thank you.
Yes, thank you.
Yes. And on behalf of the ACNS YNS, I would like to thank our chair, Professor Shingo today for your great chairing and also the great expertise. And also Dr. Xu Xinghua for your great presentation about the endoscopic evacuation of hematoma. And also Professor Syed for your great sharing on the supraorbital approach. And also, I would like to thank our discussant today, Professor Olisen and also Professor Prissett. And also thank for my co-host today, Dr. Joey Sam and Raja and Neil and Biswa and Dusort. And I hope to see you all next time in our ACNS webinar. Really huge thank you for you, and I hope to see you soon in person, my friends. Thank you so much. And thank you, Professor Kato. See you.
Thank you. Thank you.
Thank you.